45 minutes, that's too long.
Thanks for coming, everyone. For those of you that don't know me, my name's Susan. I'm a pharmacist here and I'm currently working as the program manager for the antibiotic allergy delabelling program. And I've also got Dr. Jason Tribbiano with me here as well. He's one of the ID physicians here. So today we wanted to talk to you about some current updates in antibiotic allergy. We wanted to talk to you about our exciting program and some of the initiatives we're doing here to help improve the way we ask, assess and act upon antibiotic allergy. So at the end of this session, you should be able to have an understanding of some of the gaps in practice we've seen in terms of antibiotic allergy documentation and assessment. Hopefully you'll be able to understand the benefits of formal allergy assessment and testing. We'll give you the tools to get a comprehensive allergy history. And we're going to introduce a new antibiotic allergy assessment tool to help you assign the correct allergy phenotype. We'll explain the process involved in an oral penicillin re-challenge test. And we'll give you some basic recommendations for antimicrobial prescribing in the setting of penicillin allergy. So a classic problem that we often see on the wards is patients presenting to the hospital reporting an antibiotic allergy. It might be one antibiotic allergy, it might be multiple allergies. The issue is that once an allergy label is put on a patient's history, it often stays with them for many, many years. Mr. and Mrs. Smith on the screen here both had penicillin allergies for over 40 years, and it wasn't until the allergy label was challenged with a simple test that they were able to have their penicillin allergy removed.
I've got a Cerner version of that one now. This lady has like 40 different allergies listed. You should give me that one, it's much better.
The key thing to remember here is that penicillin allergy is not forever. We know that over half of penicillin allergies are lost over a 5-year period, and that percentage will increase as time goes on further. So why do we care about antibiotic allergy? Roughly 1 in 4 to 1 in 5 patients will report an antibiotic allergy. The severity is important to us. We know that about half of these are what we call low-risk antibiotic allergy, and they're classic patients to have an oral challenge test to see if they're actually allergic or not. On the flip side, about 5% are high risk, and that carries a 25% mortality, so it's important we identify the high-risk patients and treat them accordingly. In terms of impacts on the health system, having an allergy label leads to a 25% EMI error rate. It leads to increased use of restricted antibiotics, as well as an increased readmission and length of stay. We know that it increases the incidence of resistant organisms like MRSA and C. diff, which has negative impacts in terms of their healthcare. And the end result is increased adverse drug reactions and healthcare costs. So I have a question for you. We have a 75-year-old lady with a distant history of amoxicillin-associated urticaria. She's admitted with community-acquired pneumonia. The intern asked you which antibiotic would be most appropriate for the patient.
These are real ones I made up, and there's no right answer for some of these. Sorry.
So your options are benzylpenicillin A, B amoxicillin, C ceftriaxone, D moxifloxacin.
Why you gotta put their hands up?
Is anyone game to say they chose number A?
Don't bias it.
Would anyone choose B, amoxicillin? C ceftriaxone? We have some takers.
One hand.
2, I see 2 hands. And D, moxifloxacin.
So everybody else would use moxifloxacin. Oh God help us. Okay.
Jason, would you like to provide some guidance?
Well, I think Susan will show in a minute that we should be encouraging the use of more cephalosporins in this patient. And the teaching we had in medical and pharmacy school is wrong. So certainly in this patient, when they ring me on the approvals phone, I will not be giving them moxifloxacin, and they will be getting ceftriaxone. And I agree, A and B are incorrect. So technically, moxi is correct as well, but I think we should be using these 3rd and 4th generation cephalosporins.
So if we know about cross-reactivity and a bit about the chemical structure of the antibiotics, we can get some clues about what are the right antibiotics to use. So cephalosporins and penicillins have a similar structure, which is the beta-lactam ring. I was taught at university that the beta-lactam ring was the reason for allergic reactions in these types of antibiotics, but we now know that that's not true. We know that a patient can have a penicillin and a cephalosporin, and there's no cross-reactivity between them, even though they both have the beta-lactam ring. So what is the element of the chemical structure that makes the allergy appear? We think it might be due to the R1 or acyl side chain. So we know that penicillins and cephalosporins that have a similar R1 side chain are more likely to cross-react than those that have a different R1 side chain.
Interestingly, that R2, if you go back to in cephalosporins, whilst some literature says it's an antigen, it actually doesn't do anything. It's so rapidly degraded in body that really the only things it can be are how the beta-lactam ring gets broken up or that R1 side chain.
So if we look at beta-lactam cross-reactivity, I was taught at uni that the rate of cross-reactivity between penicillins and cephalosporins was around 10%. We now know that that's a lot less, and for most cases it's less than 2%. The exception to this though is, where we've got aminopenicillins like amoxicillin and ampicillin, and cephalosporins like cefalexin that have a similar R1 side chain. The rate of cross-reactivity in these types of antibiotics is a lot higher. The other thing I should point out is that the cross-reactivity between penicillins and the monobactams is basically zero. The exception might be something like aztreonam and ceftazidime, which is a cephalosporin. They have a very similar R1 side chain and there is some cross-reactivity. But if you're thinking about monobactams and the penicillins, just think of the cross-reactivity being about zero.
So if you're asked to dispense aztreonam in the middle of the night for somebody with a really severe penicillin allergy, it would still be fine to dispense. It's a forgotten antibiotic.
The other type of cross-reactivity you might be asked about is that between penicillins and carbapenems. We know that that's less than 1%, so it's very, very rare, and in most cases it's quite safe to use something like meropenem in these patients.
If you can get approval.
If you can get approval. So why were we taught that there was a 10% cross-reactivity between penicillins and cephalosporins? It might be because early manufacturing of penicillins might have been contaminated by the other drug. It might be because the cross-reactivity studies included all types of allergic reactions and not limited to certain reactions. Or it could be because the cross-reactivity between your aminopenicillins and your first generation cephalosporins is so high, and they represent the highest proportion of these types of drugs used in clinical practice. We know that there's a higher cross-reactivity rate with first generation cephalosporins compared to our second and third generation cephalosporins as well. So something like ceftriaxone might be a good option to use in a patient that's had a documented allergy to amoxicillin. Did you want to add anything?
Cefazolin is a unique beast. So cefazolin has no shared side chains with any other penicillin or beta-lactam. So even though it's a first generation cephalosporin, I would have that in your mind as like ceftriaxone. It's just because the rate is high with first generation because it's cefalexin and Ceclor, which have that R1 side chain.
So what happens if we just avoid penicillin altogether because a patient says they have an allergy to it? Jason's got a case here where we've got a 45-year-old man admitted with Staph aureus bacteremia. His penicillin allergy was documented as unknown, so he was given vancomycin as first-line therapy. The issue is that in this setting, the Staph aureus bacteremia, there's a high mortality rate if you give vancomycin instead of penicillin. So it's really important you do get a clear history from the patient. Did the patient die, Jason? So the issue is that by not giving the most appropriate and effective antibiotic, it can lead to fatalities. And unfortunately, it was found out after the patient had died that the penicillin allergy was actually a childhood allergy. So the reality is that the penicillin allergy may have actually been lost by the time the patient presented to hospital, and we might have been able to keep that patient alive by giving them penicillin in the first place. Another question, to see if you're all awake. What proportion of patients with a penicillin allergy have the reaction listed as unknown? How many of you would say A, 5%? B, 10%? C, 15%? Or D, over 25%?
Interesting.
Interesting.
I don't know the right answer actually, it's made that up. No, our data says 18%, so somewhere in the middle there, which is pretty high.
So I guess the take-home message is that the documentation of allergies has quite a lot of improvement that needs to be done system-wide, and we've all got a part to play in that. What proportion of the recorded description in the EMR do you think would be wrong? Can anyone call out a ballpark figure? It might be true.
Come on.
By wrong, do you mean not recorded or wrong reaction?
Wrong reaction. So you go and then ask the patient, and you look back at what somebody put in Cerner 5
Okay.
years ago, and the patient is compos mentis,
Okay,
and
so-
then you say, what's the...
Right, wrong, so.
95? That'd be good for me, Keithy,
Yeah.
but it's not. It's 25%. So, and that's GenMed Austin, GenMed Alfred data, so that's local data.
Yeah.
Not after we've seen them.
Not if you fixed it now. So, before you saw it.
So,
Where's Mona? On 8 West, they're always, or 8 East, they're always done beautifully. Always.
So we did an audit of the first 60 patients that were assessed in the antibiotic allergy labelling program for the first couple of months of this year. We looked at whether the allergy documentation was complete. So we looked at whether they'd filled in the drug, had they filled in a reaction, and had they filled in the severity of the reaction. Was it mild or was it severe? We found that, and then we compared it before the nurse had come to see them and then after the nurse had seen them and updated the Cerner system. We found that using an allergy tool and assigning the correct allergy phenotype led to a change in the EMR. So the documentation increased 34% to be more appropriate, and that was a statistically significant result. The other thing we looked at is whether the reaction was listed as unknown, and we found that by having the nurse do the assessment and then make an adjustment to Cerner, they were able to create a 38% change in Cerner as well. Again,
Not
leading
quite,
to
95%.
better outcomes.
There's a lot of noise in that Cerner box though. Just go back a second. If I had time again, gee, would like to change that box, right? So you got to pick what. So I think when we said complete, we're only talking about substance, reaction, severity, not like info, source, age, category, comments, because that's impractical. But those three.
Yeah, so the things with the stars are the key things that we need to be thinking about. So on the flip side, what happens if we put an allergy into Cerner and it's actually inaccurate? This is a real life case that we saw earlier this year. There was a 50-year-old man who was admitted for nephrectomy and iliac mass resection. His allergy was reported as penicillin, but there was no documentation of what the reaction was or what the severity was. So he was given ceftriaxone and metronidazole post-operatively. He then went on to develop some lip swelling, and he reported this to the ward staff, and no one triggered that it could be an allergic reaction, so the antibiotic was continued. And it wasn't until the allergy nurse reviewed him and took a history that the warning bell started ringing, and she thought, well, this sounds like it could be angioedema. And she found out that the patient had an allergy to ceftriaxone documented in 2018. So the take-home message, I suppose, is always recheck allergy history when a patient's readmitted, because the documentation may be inaccurate from one admission to the other. So what are the solutions that we're trying to solve with our program? We know that 50% of all allergies are low risk. We know that over 90% of low-risk penicillin allergies can be removed with an oral penicillin challenge test. And we also know that access to allergy clinics is quite poor. Only 57% of Australians have skin testing available to them. That might be due to long waiting times, or it might be due to geography limiting them visiting the clinic. The program that we're running at both Austin and Peter Mac will help to provide the solution, and as well as improving the way we document in the EMR.
I think we've got 600 people on the wait list to be seen in the outpatient clinic, so it's just impractical, unfortunately, to see them all as an outpatient.
It's about 2 years, isn't it?
Yeah.
So the antibiotic allergy delabelling program is supported through a Better Care Victoria grant. We're upscaling an existing program that's been running at both Austin Health and Peter Mac since 2015. And the program has 3 components. The first step is to discover all patients with an antibiotic allergy, and that's where our nurses and pharmacists come in. The second step is to assess the allergy appropriately. So we'll introduce a new tool to make it easy for all pharmacists and all nurses to assess allergy consistently and appropriately. And the third step is to find our low-risk penicillin patients and offer them a really safe and simple penicillin oral test. So that we're trying to get staff to think about the 3 A's of antibiotic allergy to help the way we manage allergies for our patients. We want staff to ask about antibiotic allergy. We want them to assess the level of allergy risk using the tool. And the third step is to act appropriately based upon the information collected. So when we ask about antibiotic allergy, there's a few things to think of, but I'll start off by asking another question. We've got a 35-year-old man who has a recent history of anaphylaxis to cefalexin. He tells us that he's tolerated amoxicillin without any issues on several occasions previously, and he's admitted with tonsillitis. So with this information in mind, what antibiotic would you recommend? Any takers for A, benzylpenicillin, B, ampicillin, C, cefazolin, or
Nobody's
D,
recommending anything.
cefalexin? Everyone's on the fence.
So
Jason, what would you-
he's been given ampicillin before though, so why, amoxicillin before, why can't he have ampicillin now? Anybody? No? Okay.
I would probably say you could. I just
Probably-
wouldn't know which one's first line out of Ben Penn or
Okay. So let's say I'm TG. TG says Ben Penn is first line. Would you
Is
give me Ben?
ampicillin recommended at all?
No.
Okay. I would probably call Iderius.
Good one. This is a common scenario though, right? And then often the young medical staff will ask the pharmacist what I should do for this patient. And we ask the pharmacist this question for me, often give the wrong answer actually, so that's what we do.
So if we take a step back, if someone tells you they've had a history of anaphylaxis to an antibiotic, without looking at the assessment tool that I've given you, would you think that would be a low risk or a high risk allergy? High risk
Yeah.
allergy. So would you be reluctant to give cefalexin to that patient?
Yes.
We
No,
would
we
not want to
can.
give anaphylaxis
Don't want to kill a patient, right?
to a patient. The next thing to think about is if there are penicillins there, is there a cross-reactivity issue? Which penicillins listed there might have a cross-reactivity to cefalexin?
Ampicillin, right?
Ampicillin,
Yeah.
perfect. So that one's not appropriate.
So the take home is what they've tolerated pre is irrelevant. It is only important what they've tolerated post an index reaction. Because we often see notes from doctors, pharmacists, but they've had X before, which is completely irrelevant. The clock starts again. So the person has a Keflex allergy, you definitely want to avoid Keflex. You want to avoid anything with a similar R1 side chain. So amoxicillin, ampicillin is a no-go. And really, I put this up here because they're all wrong. Because if somebody's had a severe anaphylaxis to a cephalosporin, you're going to avoid both penicillin and cephalosporins.
Cefazolin's a different
Cefazolin, if you push me, I would give it, right? But that's not something you would recommend on the spot, okay? it's likely they'll tolerate cefazole. Okay? And you know, we've got lots of these come to clinic. So 40% of our Keflex anaphylaxis patients that Claire sends me from the Adverse Drug Reaction Committee will be positive to ampicillin on the skin, which is a huge proportion, right? So that just demonstrates that cross-reactivity. But they all go on to tolerate benpen and another cephalosporin. But that's only after testing. Okay, so I think for this one, you avoid all those.
So contact ID.
Contact me.
And just remember that tolerance before a reaction doesn't predict tolerance post. So remember, like Jason said, to start the clock again once an allergy occurs, and be suspicious of any new antibiotics that are being prescribed thereafter. So what questions make a good allergy history? There's 3 key things I want you to take home. We want you to think about the severity, the timing, and antibiotic tolerance. So if we're thinking about severity, we want to know, is the allergy severe or is it not severe? Some questions you can ask to help you ascertain that are, do you remember the details of your reaction? How was your reaction managed? And did it require treatment or hospitalisation? If the patient tells you, oh, I had a severe anaphylactic reaction to penicillin, and you say to them, well, how was the reaction managed? They said, oh, I went to bed and I woke up and I felt fine. That gives you a clue that perhaps the history they're giving you is not particularly reliable.
Yeah, technical.
So the second step is timing. Was it an immediate reaction that occurred within hours of the first or second dose, or was it a delayed reaction? Did it occur 2 to 3 days after antibiotics were started? So you can ask how long after taking the antibiotic did the reaction occur, and how many years ago did the reaction occur? And then the third step is the tolerance. You can ask something like, were there any other antibiotics, such as penicillins, you've taken without a problem since you described your penicillin allergy?
We find in clinic, most people will say, penicillin, I don't know, but you probe them, they easily give that information. And the big one is about timing. Like, so I don't remember, and you say, oh, was it right after the first dose? And they go, no, it was hours or days later. And automatically, that's a huge difference in the allergy description.
Quite often, patients will be quite vague about their history, even though you're asking these questions, or they might just not know. So really just go with your gut. Let the time from the reaction and the severity, what they're telling you about their treatment, hospitalisation, guide you in terms of making an assessment of what you think the allergy severity might be. What I might say is to open your packs. We've got some little presents there for you. There's a pocket card which has the questions we'd like everyone to ask to get a good allergy history. So that might be a good tour to take with you when you go to visit your patients.
I hope you can all read the pocket card. We tried bloody hard, but it's a lot of information. Focus on the questions. The grid's a bonus, all right? It's the questions that's important.
And the other thing I've got is the new allergy assessment tool that we're introducing across the hospital. Once you've taken your allergy history, we want you to document the allergy history on the first page of the form. So you'll see that we've got the 7 antibiotic allergy assessment questions. Just having the tool is stuff you're already doing, but it's just a way of documenting it formally and making it consistent across the hospital and across different disciplines of the hospital.
Did you get the short stay guys here? I was talking to them and I asked them, I'll tell you all the questions you asked in allergy history, and they all got these questions as a group. But some didn't do this one, some did the other. So it's just a way of making sure we ask the same ones all the time. I bet you ask them all anyway.
So the next thing to think about is assessing the antibiotic allergy. I thought we'd just give you a quick recap on the difference between type A and type B ADRs. So our type A ADRs are essentially side effects. They're predictable, they're dose dependent, and they don't involve the immune system. Common examples include GI upset, headache, and confusion. Our type B ADRs are what patients will refer to as their allergic reaction. They're unpredictable, they're less dose dependent, and they involve the immune system. It could be T-cell mediated, which might present as a delayed allergy, or it might be an IgE mediated ADR, which would be immediate symptoms such as anaphylaxis. It's important that we know the difference between the two, and we're able to define them properly because both can lead to inappropriate allergy labels on the history and therefore inappropriate antimicrobial prescribing. Did you want to add anything, Jason?
No, it's a boring slide.
So a tool that can help you. So on the back page of your allergy assessment tool, looks quite scary, but with practice I'm sure you'll agree that it's not. What we've done is that we've split different types of presentations of allergy into certain body systems. So we've got a section for dermatology, respiratory, haematology and others. Against each type of sign or symptom, we've then put a traffic light system to help you work out what the allergy phenotype might be. So our reds are our high risk allergies. So a common example might be a skin shedding type of rash, which tends to be a delayed reaction. Your oranges are a moderate risk, which would require a specialist skin test. A common example might be some angioedema. And then our greens are our low risk patients that are perfect for an oral penicillin rechallenge. So I've boxed a few of those: a childhood rash, a rash more than 10 years ago, an unknown reaction more than 10 years ago, or family history. They're all perfect patients to refer to us for testing. And then our white section is for our no risk allergy, and they're our side effects. So there'll be things like your GI symptoms, your neurological manifestations like headache as well. And they're patients that are perfect for the ID team to come and review and to directly delabel the allergy with their consent.
So we know pharmacists like putting things into a box, so you cannot complain there's not enough boxes, right? A lot of the time though, we've done this for ages. I don't think I've ticked one haematological, right? It's really uncommon that a patient will say it. So most of the time you are going to be looking at a dermatological column. Somebody's going to say rash, okay, what kind of rash things are they reporting? And half the time it's unknown. Lots of the oldies, unknown, on your gen med ward, unknown more than 10 years.
So a lot of you know Misha, one of our pharmacists here. She developed this tool as part of her master's program. She tested it, gave some training to nurses and pharmacists, and found that the sensitivity for using the tool was really high once that training had been undertaken. And pharmacists and nurses were the best two craft groups at completing the tool accurately and completely.
So it was daylight between pharmacists and junior doctors, like daylight. It was strong.
Question there.
Yeah.
With the no risk, the direct delabel, is that still done by the ID team though, as opposed to us just marking it off?
Some pharmacists like to mark it off. So if you ask Andrew in ED, he just takes it off, okay? But if you're more apprehensive, I'm very happy to take it off. But it's no point, what we found is there's no point taking that off unless you discuss it with the patient and treating team, right? Because you can take it off, the patient's going to come back and say, I'm still allergic. So we've made a point that we don't directly take it off unless the patient is accepting of that and the treating team know, because otherwise it's a waste of time. And then every time we do one of these things, the patient gets a letter and their GP. It says, okay, you have been delabelled, we've got like this standard spiel to side effect, blah, blah, blah.
The other thing with that is that, because sometimes I'll just change it to the intolerance.
Yes.
Sometimes I'll say to you, it was so bad, I never want to have it again.
Yeah, I don't think that intolerance box is any good because nobody looks at it. And I can tell you the clinicians don't. So they just see penicillin, intolerance, still avoid. So I think if there's going to be that, then it probably needs a comment. That's why it's too much time consuming. Well, you guys, I know you do it just in Germany instead of North, but sometimes it's easy for us to come around and say, okay, we've talked to the patient, they think it's crap, they've had Keflex before, they can have that or trial penicillin if we leave it in to leave some context. But gee, I hate those white ones. I really hate them.
So this slide just really runs through the benefits of getting the phenotype right in the setting of penicillin allergy. So the matrix has whether it's immediate or a delayed reaction, or whether it's severe or non-severe. So your immediate severe reactions like anaphylaxis, we've said that you can use a non-reactive cephalosporin with caution. Your delayed and severe reactions, such as a scar reaction, you absolutely want to avoid cephalosporins because the risk of anything going wrong is just too high. For your immediate non-severe reactions like